Welcome to today's Explainer. We are going to map out the complete step-by-step clinical workflow of wound management and infection prevention. So whether you're a nursing student gearing up for exams, a seasoned healthcare pro brushing up on clinical protocols, or just someone fascinated by how the human body actually heals itself, you are absolutely in the right place. We're going to break down exactly how we assess tissue damage, identify microscopic invaders, and deploy evidence-based treatments on the front lines of care. Here is our game plan for today. We'll be moving through 4 main stages. First up, breaking the barrier. Second, identifying the threat. Third, the art of healing. And finally, number 4, the ultimate shield. We're going to start right at the site of tissue damage and work our way all the way out to systemic infection control. Let's get into it. Section 1, breaking the barrier, when the skin fails. So we're kicking things off with the physical trauma of wounds. Think of your skin as a literal suit of armor. When that armor drops, whether it's from a thermal burn or localized mechanical pressure, a whole cascade of systemic risk kicks into gear. Let's start by looking at a superficial first-degree burn. With this type of injury, the damage is strictly limited to the very top layer of the skin, the epidermis. Clinically speaking, it's going to present as pink or red with very minimal edema or swelling. It's definitely sensitive to touch and temperature changes, kind of like a really nasty sunburn, right? But the good news is it doesn't lead to scarring and your skin's barrier function is still largely intact. Now, when that damage pushes deeper, we're dealing with a second degree, or deep partial thickness burn. Here, the destruction punches right past the epidermis and goes straight down into the dermal layer. The skin gets this mottled appearance, and you'll start seeing these large, thick-walled, fluid-filled blisters. But here is the crucial takeaway for patient care. Touching this kind of burn causes severe, intense pain. Why? Because the nerve endings that live right there in the dermal layer are now totally exposed to the air whenever those blisters break open. So that brings us to the full-thickness, third-degree burn. And there's a really surprising fact about this one. The damage here goes all the way through the dermis, leaving only the subcutaneous tissue exposed. The skin is going to look dry, leathery, and maybe red, waxy white, brown, or even black. But despite being literally the most physically destructive type of burn, it is initially completely painless. The trauma is so incredibly deep that the nerve endings themselves have just been completely destroyed. At this point, every single body system is affected, triggering a massive immediate immunologic response and massive fluid edema. Shifting gears away from burns, we absolutely have to assess pressure ulcers, which are commonly known as bed sores. These happen when localized ischemic tissue damage occurs just from the constant pressure, shearing, or friction over a bony prominence. They start at stage 1, which just looks like persistent redness, warmth, or swelling where the skin is actually still intact. But if we don't relieve that pressure, it cascades incredibly fast. By stage 2, you've got a shallow crater or a blister. Stage 3 is a full-thickness wound extending deep into the subcutaneous tissue. And by stage 4, you are dealing with extensive necrosis. It literally excavates a deep crater that completely exposes the underlying muscle, bone, or tendons. The barrier hasn't just failed here, it has been entirely wiped out. Which brings us perfectly to section 2, identifying the threat. Are microscopic enemies. Because an open wound is never just a structural problem. It is basically an open front door for pathogens. Once we've done our physical assessment of the damage, we have to pivot straight to diagnostics. We have to answer one absolutely crucial question. What exactly has invaded this compromised tissue? If we don't know exactly what microscopic enemy we're fighting, all our treatments might be completely useless. To get that intelligence, we rely heavily on the wound culture and sensitivity protocol. First, as a nurse, you have to meticulously swab the deep interior of the wound itself using strict aseptic technique. You literally never just swab the surrounding skin because if you do, you're just going to pick up normal surface flora and ruin the test. Next, the lab runs a gram stain to give us some rapid initial data, followed by a 48 to 72-hour culture to actually grow and definitively identify the specific organism. Finally, they test it for antibiotic sensitivity. So the absolute golden rule in clinical practice here is this. You must obtain this culture before starting the patient on any broad-spectrum antibiotics. If you don't, you run the risk of completely masking the true identity of the invading bacteria. And why are we so obsessive about getting this specific identification? Because of microscopic nightmares like MRSA, methicillin-resistant Staphylococcus aureus. This is genuinely one of the most terrifying threats we actively hunt for.
It's a mutated superbug that just explodes in growth the second our natural defenses break down. Now, regular Staphylococcus aureus is pretty common, but this specific methicillin-resistant strain, it outright ignores standard antibiotics like penicillin derivatives and cephalosporins. If you guess blindly with your antibiotics instead of running that sensitivity test, MRSA is just going to continue to spread right under your nose. All right, Section 3, the art of healing. Let's talk battlefield tactics. Now that we've sized up our enemy and the extent of the structural damage, we enter the treatment phase. Let's look at the actual clinical interventions we deploy to heal that tissue. It's important to remember that different wound etiologies demand entirely different nursing interventions. For instance, severe burns require really aggressive debridement, which means physically removing the dead tissue, followed by strict twice-daily dressing changes, direct topical antibiotics, and usually eventual skin grafting in the OR to permanently cover the defect. Pressure ulcers, on the flip side, are a different ballgame. They rely heavily on fixing the root cause, which means mechanical pressure relief. We put patients on specialized beds, turn them strictly every 2 hours, perform active range of motion exercises, and utilize moist saline wound therapy to jumpstart the body's own natural healing mechanisms. Let's actually zero in on that moist saline therapy for a second. When you're caring for an ulcer, evidence-based practice dictates a very precise procedure. First up, you irrigate the ulcer using normal saline at a highly specific, gentle pressure of 4 to 15 pounds per square inch. This removes the debris without accidentally destroying the fragile new cell growth. Then, you carefully blot the surrounding healthy skin dry, moisten a sterile gauze with a saline, and gently place it inside the wound. Now, huge patient safety alert right here. You must absolutely avoid using cytotoxic cleaners inside an open healing wound. I'm talking about things like hydrogen peroxide, povidone iodine, or acetic acid. Yes, they definitely kill bacteria, but they are also highly toxic to the exact new cells your body is trying to use to rebuild that tissue bed. Okay, Section 4, the ultimate shield, infection control. We've zoomed in on localized tissue damage, we've done our diagnostics, and we've covered bedside wound care. Now we need to pull way back and look at the systemic, hospital-wide protocols that keep literally everyone in the facility safe. The entire backbone of universal precautions really boils down to one simple, completely non-negotiable directive from OSHA. You have to treat all human blood and designated body fluids as if they are already known to be infectious. You don't sit around waiting for a positive lab test to put on your gloves. You must assume every single exposure is potentially lethal, treating any contact as if it's infectious for HIV, hepatitis B, or other severe bloodborne pathogens. To actively maintain this ultimate shield, healthcare workers rely on strict barrier precautions. We're talking gloves, masks, protective eyewear, and gowns anytime you even anticipate contact with high-risk fluids. Obviously, this includes blood, but it also includes cerebrospinal fluid from the spine, synovial fluid inside the joints, fluids from the lungs and heart, amniotic fluid, and reproductive secretions. Now, an interesting little caveat here. Unless there is visible blood present, things like everyday sweat or tears actually aren't on this high-risk list. But for the fluids we just named, appropriate personal protective equipment is non-negotiable every single time. As we wrap up today's explainer, I want to leave you with a slightly provocative thought to chew on. We just spent all this time talking about really complex burn classifications, lab cultures identifying mutated superbugs, and intricate surgical skin grafts. But at the end of the day, despite all of our incredibly advanced antibiotics and space-age medical technologies, the simple, rigorous, everyday act of hand hygiene remains the undisputed heavyweight champion in preventing healthcare-associated infections. Seriously, washing your hands thoroughly before and after every single patient contact breaks the chain of infection faster and way more effectively than anything else in our toolkit. It really is the foundation of everything we've covered today. Thank you so much for joining me on this clinical journey through wound care and infection control. I hope this structured breakdown helps you truly grasp how the human body heals itself and exactly how clinical science steps up to defend it. Keep learning, stay curious, and I'll catch you on the next explainer.